Okay. So as I mentioned this morning, we're going to continue our discussion about wastewater science, but switch gears a bit. To lead our afternoon discussion, we're honored to have Dr. David Persse present our afternoon keynote address, along with co-presenters, Drs. Ensor and Stadler. Then Dr. Persse will moderate a panel of experts who will discuss the implications of wastewater science from diverse perspectives. So first, let me introduce Dr. Persse. His career started in medicine about 10 years, with 10 years of experience as a field paramedic and a paramedic instructor in upstate New York and New Jersey. After receiving his pre-med training at Columbia University in New York, he then attended Georgetown University School of Medicine. Dr. Persse then completed residency training in emergency medicine at Harbor UCLA Medical Center in Torrance, California. After residency, Dr. Persse completed a resuscitation research fellowship at Ohio State University. Dr. Persse was then awarded a grant from the Society for Academic Emergency Medicine and completed fellowship training in emergency medical services and resuscitation at the Baylor College of Medicine and the City of Houston Emergency Medical Services Program. In 1996, Dr. Persse became Director of Emergency Medical Services for the City of Houston. In May 2004, he was appointed by City Council as Houston's Public Health Authority, and that's how we know him. He is also a tactical physician with the Houston Police SWAT team. During the COVID-19 pandemic, Dr. Persse was named the Chief Medical Officer for the City of Houston. Dr. Persse is responsible for the medical aspects of clinical care quality management, disease control, and public health preparedness. Dr. Persse is also Professor of Medicine and Surgery at the Baylor College of Medicine and Professor of Emergency Medicine at the UT Health Houston McGovern Medical School. He's also a hockey player so please join me. Yes, Bob. Please join me in welcoming Dr. Persse to the podium. You got it. You're welcome. Thank you.
Okay, thank you, everyone. Just one little correction to that. It's the Ohio State University. So we have any Michigan fans in the room? Yeah, well, whatever. In spite of that, we're going to go on. So the keynote address is usually given by one person, but this is such an incredible topic that from my standpoint, one person, certainly this person, could not possibly do it. So I'm really proud to have a team of folks that are going to be giving the talk this afternoon. And they're going to include Dr. Katherine Ensor. Come on up, come on. And Dr. Lauren Stadler. Now, we're all going to sit up here. So the slides are up here, so you can do it. And then I'll give I'm batting cleanup. I'll give the last few slides, and Dr. Ensor is going to give it. But we are really, I got to tell you, the three of us represent, as you probably already imagined, a really pretty large team of really innovative thinkers. And I wasn't here this morning, but I've heard a little bit about the talk that went on this morning, and I certainly can't overshadow this morning's talks, but this whole thing with wastewater, if you know the history of public health and you go back to, I forget the date, in London, right? I mean, to some degree, public health, in some degree, we've come full circle with looking at wastewater for a major, what's the right word? Not a contributor, but a major component to managing public health. So it's sort of interesting, I think, if you look at that perspective, to some degree, we've come full circle, but today we're far more high tech. My two colleagues here are going to delve into that a little bit. With that, I'm going to get out of the way. And Dr. Ensor, you have the podium to begin with. So, no, I'm sorry, Dr. Stadler has just hit there in advance.
Okay, wonderful. All right, good afternoon, and thanks everyone for sticking with us. I'm really excited to kick our team off here, and we're focusing on how wastewater monitoring is used to inform public health action. So I'm going to start by just kind of giving us a booster and an overview of how our system works here in Houston. And then I'll hand it over to Dr. Ensor, who will talk about how the data is analyzed, and then Dr. Persse, who will talk about how this information is used for public health intervention and public health action. As you know, many people have said this morning, and Dr. Persse just said, this is the work of a really large team. Our Houston wastewater epi system is really led by Dr. Hopkins, who is not here today, Dr. Ensor and myself, and we kind of divided in a very similar way that Anthony said this morning in terms of I'm the wastewater person. You know, I've been working on wastewater microbiology since I started my own lab. Dr. Ensor is our statistician and leads the analytics. And then Dr. Hopkins leads our implementation and leadership. And you can see with all the different names here that there's folks from Houston Public Works, from Rice, from the Houston Health Department, who work together every single week to not just collect these samples, hand these samples off, analyze them, and then convert them into actionable information. So it's really a huge collaborative effort. And of course, I think one of the reasons that our program has been so successful is because of the leadership at the city, specifically from Stephen Williams, Dr. Persse, and Carol Haddock, who's the Director of Public Works, and their openness to embrace innovation in this space and really see the promise of using wastewater surveillance for the protection of public health. And really, without their support from the early days of the pandemic, this wouldn't have been as successful as a program as it is now. Last acknowledgement side, I like to put these up front, so make sure I get through them all. There's so many people who have contributed to this program that I can't name every single one. And over the 3+ year history of it, who've helped with the analysis, the method development, with the collection of these samples that are listed here. This, again, would not have been possible without their help. Okay, so to give an overview of kind of where we started, where we are now, and where we're going, this is a timeline. It's probably pretty tiny. You can't see it very well of kind of since the beginning of the pandemic. So the big pandemic moments are shown in blue, and then real milestones in our wastewater surveillance system are shown in orange on top. And so as soon as the city shut down, we were at treatment plants, you know, sniffing around to see if we could get some samples to look for this virus. I think Dr. Marissa's group was doing this, my group was doing this, and then Dr. Hopkins found out that we were working on this, and we all kind of joined forces together to really work, you know, in real time to develop, validate, and produce data that we could believe in that would be useful in terms of tracking infection dynamics across the city. And within a few months, we were generating data. And since then, this program has just expanded. So we expanded to not just citywide surveillance, but also facility level surveillance. And we'll talk a lot more about that later in this talk. We've added sequencing to look at and bioinformatic pipelines to look for emerging variants of concern and characterize cryptic variants that are circulating in our communities. We were named a Center of Excellence, which I'll talk a little bit more about as part of the CDC's National Wastewater Surveillance Program. And we've added a lot more additional targets and also worked very closely with the health department to define what happens with that information after we detect it at a citywide level, but also in these facility level samples. So as I mentioned, we were named one of the inaugural National Wastewater Surveillance System Centers of Excellence by the CDC. And in this capacity, we do a lot of work that's focused on providing support and innovation in the space of wastewater surveillance. We've developed a lot of resources that are very specifically focused on wastewater surveillance, not just the laboratory methods, but also the analysis of that data, and then how to integrate that data with other disease surveillance, existing disease surveillance data. We've created some training courses and videos that are available on our website. And we also do consultations with health departments all over the country to kind of help them get up to speed, because it's a huge, you know, some people have never thought about wastewater at all, whereas other places in the country, they have very advanced wastewater systems. And so we'll work with them and even collaborate with them to really kind of define what the priority is for innovation in this space. You know, some of the work that we've done is focused on cluster analysis for prioritizing locations for wastewater surveillance. And Dr. Ensor can tell you more about that. But we have a lot of these resources on our website. Okay, so here's a map of Houston. And one thing that's kind of unique about Houston, which actually makes it kind of an ideal place to implement a really massive wastewater surveillance system, is that we have 39 wastewater treatment plants. And I think there's a utility person here, but most major cities have maybe just a couple major wastewater treatment plants in their community. The fact that we have 39 is kind of is odd in that it's a lot. And these treatment plants vary in terms of size. So the largest one serves over 500,000 people, and the smallest one serves under 1,000. And so we monitor at all these treatment plants. And the fact that we have 39 gives us these both spatial and temporal picture of viral levels and pathogen levels across the city, just by collecting at these existing treatment plants. And in addition to these 39 treatment plants, we also have samplers located at lift stations, which are basically locations within the sewer shed where wastewater is pumped up so it can flow by gravity to the treatment plants. And these lift stations allow us to break down some of the very large wastewater treatment plant catchment areas into smaller communities. So for example, for this 500,000 person sewer shed, we can break that into slightly smaller communities by sampling at the lift stations. And then really the majority of our sites now are manholes. And so these manholes are actually getting facility wastewater samples. And the health department really early on invested in buying tons of these refrigerated auto samplers and installing them all across the city. And these are located at public schools, so K through 12 schools. We have about 48 schools now. Homeless shelters, nursing homes, and the jail. And we'll talk about how these different samples give us different information. So as an overview, we get weekly samples from each of these locations. It's something like 120-ish samples a week. I'm not really sure. It fluctuates from week to week. Those samples are collected by Houston Water or the Houston Health Department. They're transported to my lab and the Houston Health Department lab, and then Baylor also participated in analyzing these samples in the early days of the pandemic, or for the first year about. And then we have 2 independent labs running these concentration, extraction, and quantification of viral levels. And we also do some sequencing to identify variants of concern and identify some of these cryptic lineages as well. This information is input into the statistical model that identifies areas of the city that are experiencing increases and used to generate these figures that make up a report that goes to the health department. And so Kathy will talk about some of the analysis, and Dr. Persse will talk about how that report is used. But that information is used to to inform interventions and actions from the health department. So here I'll show just some of the kind of the totality of our citywide data that we have collected over the past 3 years. So each on the x-axis is time, and on the y-axis is a viral load, which is simply the concentrations for SARS-CoV-2. So the concentration of that virus that we measured in that sample multiplied by the flow rate of the wastewater treatment plant that we got it from. And that flow rate will kind of gives us basically a population normalization to some extent, because large treatment plants represent many, many more people. And then each one of these dotted lines represents an individual wastewater treatment plant, and then the citywide level, which is these lines aggregated, is shown in the solid green line. And I'm not sure if you can see the gray, but there's a 95% confidence interval around that. And you can see this line, really captures the surges of COVID that we've experienced in the city. So the beginnings, that first wave, and you have Alpha, Delta, Omicron, BA.5, XBB, and then the most recent one was a mixture of variants actually. But each of these surges was really captured in these wastewater levels. And we can compare it, to the available clinical data, which we've seen probably time and time again now, but here we're showing that citywide viral level. Now it's just showing a benchmark value. So we benchmark it all to that first peak that we experienced in Houston. And in the blue, we have the 14-day moving average of the clinical positivity rate. And as you can see, these are, very highly correlated with each other, to the point where you can use the wastewater to nowcast and even forecast positivity rate in the city. And this is increasingly important because the positivity rate data is unreliable now. We're not getting positivity rates anymore. We're just getting a number of positive cases across the city. But because we have this massive amount of longitudinal data now, it's that we can trust the wastewater to tell us about community levels within the city. So in addition to the citywide surveillance, we also do facility level monitoring. And one of the programs that we're really excited about and that we're investing a lot more time and research into is our school monitoring program. So there's about 49 schools, I think, now enrolled in this. And these are shown on a map here. So they're in 3 different clusters around the city. For each of these schools, we've identified a manhole that only gets wastewater from that school. And there is an auto sampler that's either located in that manhole or right next to it that collects a sample, a composite sample across the school day. So it basically collects a little bit of wastewater and saves it in this refrigerated auto sampler across the school day. And then we grab those samples, bring them to lab and analyze it. And at this point, we have we're going on 3 years of data for SARS-CoV-2, but also influenza and RSV we've started monitoring for. So we are looking at respiratory viruses, and now we're expanding to other pathogens as well that are specifically, disproportionately impact children. And so one of the things that the panel brought up was, how do we decide kind of what to look for next, or how do we prioritize what's most important to monitor in wastewater? And whether you use agnostic or targeted methods, you still have to make some decision about what's important from a public health point of view. And so what we decided to do was to form an advisory committee. So we formed a committee of infectious disease doctors that are all located here in Houston. This is led by Dr. Septimus and Dr. Persse. And then we surveyed these doctors and we asked them to prioritize, basically looked at all the reportable diseases over the past several years. We gave them this list of diseases and we asked them to rank them in terms of 2 things. One was public health importance and the other one was actionability. And then after they ranked all these diseases, we basically did a weighted combination of those 2 things to come up with priority pathogens to monitor. And in addition to this ranking, we also asked them to indicate where it would be most valuable to monitor these. So citywide versus, school-age populations versus nursing homes or homeless shelters. And then we used the results of this survey. So we did this locally. We also disseminated this survey nationally, which we're still actually in the process of getting data back for and analyzing. And I'll show kind of a overview of the results here in this table. This is the list of pathogens that were identified by the survey of these infectious disease doctors. And importantly, we did not ask them to think about whether it could be detected in wastewater or not. We thought that was our problem to deal with after the fact. Of course, that would be very important for understanding whether or not wastewater surveillance would be useful or applicable. But in this case, these are infectious disease doctors. We really wanted them just to prioritize things based on importance and actionability. And as you can see, they came up with a diverse list of pathogens, from bacterial pathogens to vector-borne viruses to antibiotic-resistant bacteria to fungal pathogens. And they also indicated kind of where we should prioritize our efforts in terms of monitoring, citywide versus schools versus congregate living facilities like nursing homes and homeless shelters. And so this is really what we've been using to think about how we prioritize assay development, but not just development, but implementation and piloting. And so my group has been working to develop assays that give us quantitative information about the abundance of all these targets. And we use the results of that survey to decide what to work on. And our goal now is to do a couple things in parallel. One is to get baseline data. It's really important to see, okay, what are the levels that we see in wastewater, just routinely? And that allows us to understand how we should decide whether or not changes in those levels, or maybe it's never detected and it's when we start to see it, it becomes an issue, how that information is going to be used to actually inform an action. And then what other information we want to use in parallel to the wastewater information to decide if this is a emerging health risk. Okay, so now I'm going to hand it over to Dr. Ensor, who's going to talk about the analytics piece of this.
Okay, so I'm Kathy Ensor. I'm a professor of statistics at Rice University, and it's super excited to be here and to be a part of this amazing effort over the past 3 years. It's really been a labor of love, I think, and so it's a phenomenal team from all over Houston, and it's wonderful to have been a part of it. So I want to hopefully make 3 points. First, wastewater epidemiology does support citywide planning and targeted interventions. We're very successful at that. It's important to understand, however, that wastewater measurements come with natural sources of variation. And I'm the statistician, so statisticians always talk about variation, right? So you can kind of expect that. But I want to, now that the field is matured, I think that we really need to start embracing the fact that a measurement does have natural sources of variation. And so how do we quantify our certainty of the estimate for our viral load, for example? And then I'll just discuss briefly how the school monitoring is supported by strong statistical science. So we have a nice paper on looking at how strong these correlations are between wastewater and all other indicators of what's going on in COVID, and so you do see those alpha, delta, and Omicron spikes at the beginning, and you see the ED visit rate, the general bed rate, and ICU bed rate, along with wastewater, and so wastewater really can help us understand what's going on and help us in our planning processes. It's very forecastable, so I can easily nowcast as well as forecast 1 to 2 weeks ahead. And so if you look at this heat map, the columns are dates and the rows are each wastewater treatment plant. At the top is the total for the city. And what you're looking at is the 1 week change of the modeled trend. So the 1 week % change is relatively consistent across the city. If you can see the bands of oranges, those are all of our peaks. The top 5 wastewater treatment plants represent 1.6 million residents. So understanding the population of each wastewater treatment plant explains some of the patterns. So what's going on in each of our communities? So on the positive, I guess you're all aware that we did recently have a current wave, but we are beyond it, and so that's good news. But as we notice, there's still some late virus level changes in the smaller regions, which are in the lower part of the heat map. So I want you to understand that this data is messy. So this is our analyst view of what goes on, and we do this for each treatment plant. So we do this weekly. The data comes to us on Friday, usually by noon. We have our report turned around by 2 or 3 p.m. So it's an automatic process, but part of that process is the human look at this graph. So every dot on this graph, every color on this graph, every symbol on this graph means something to the analyst. And for example, I picked one where the data is actually pretty clean, but if you see a circled spot, that means that there's something going on there. Maybe we only have one replicate, or there wasn't flow, or something, it was missing and something had to be estimated. And you also see the interlab variability. And so if you just take this data without really doing any processing of it, all that measurement uncertainty is coming in. And so I do believe that we need to help the public with our analytical skills to synthesize the information that comes in. And you see kind of roughly the green curve that's running through this is a rough synthesis of what this particular wastewater treatment tells us. Plant tells us if you go to the end, you see that it's nicely decreasing, but again, you see that strong separation between the 2 labs for this particular week. And this is all on a log 10 scale. So if I reverse this transformation, then those differences would be quite large. And so let's hit on that a little bit more. So just looking at this slide, I want you to think intra-lab and inter-lab variation. So in the intra lab, so those are the technical replicates, a fourth of the measurements have a coefficient of variation above 18%. So that means the variability between the technical replicates divided by the sample mean, that metric, 25% of them are above 18%. So it's not that we can just take a measurement and just say, first of all, you should definitely be doing technical replicates because if we have this level of variability, then we at least want to capture it. Then if we add on the idea of a second lab, and this is correcting for natural interlab variability, so they've been put on the same scale. But even in this case, a fourth of the measurements, if I look at the ratio between the lab values, a fourth of the measurements are above 1.5. Okay, and again, this is on a log 10 scale. And so you see the nice scatter plot here between the two labs. So certainly they're giving us the same sense of information, but that exact number is going to have this natural variation. And so the takeaway here is it's really important to factor in replicates to the sampling plan as you're developing your wastewater system. If you're wealthy enough to have duplicate labs, that's a bonus. I don't think that the general population understands this, so I do think it's an important point for the scientists to bring forward. So Dr. Stadler pointed out that we do have lift station information. So this is a quick look at that lift station information. And so we took the largest wastewater treatment plant, and then we broke out the different 4 of the lift stations in this region. Lift stations are actually hard to sample. And so we want that information to be very valuable if we're going to go to the trouble to retrieve it. And so we have a paper that's coming out where we do this comparison between the signal that we would get from just sampling the treatment plant, which is easy to sample, versus going into the lift stations. And the really large lift station, which is lift station A, I believe, not sure where the ordering came in, but no, it would be B, lift station B. So it's giving us basically the same signal, but we do see that it never really dropped quite as low as the overall wastewater treatment plant. The other piece that I want you to focus on here is that if the modeling that we're doing allows us to separate out these different sources of variation. And again, I think that that's critical as scientists, that we understand the variability in our data. And so there's the sampling and lab variability. So we're not going to be able to separate those. We do have the technical replicates at the lab, but we only really get one sample each week. And so if you'll notice that this variation is largest in the smaller lift stations. And so it's like 0.27 as opposed to 0.03 for the wastewater treatment plant. And so that's probably due to the sampling variation. So just sampling at these smaller lift stations, we're going to see a lot more variation. The lab variation should really be constant across all of these. And so then I'm able to separate out with the methodologies that we've used, I'm able to separate the variation in the trend, which is what we care about for communication to the public. It's what we can use to decide whether things are increasing, decreasing, how confident are we in our forecast in the future. And so all of this is set up to support that. And then what you notice here is the modeling method that I've chosen. The variation in the trend is actually very consistent across the large wastewater treatment plants and the smaller lift stations. So I see that as a big success. So moving on to the schools. So this is, from the technical side, how do we look at new information when we're not really ready to quantify it? We're not ready to look at trends. So we break it up into whether the sample was positive, inconclusive, negative, or not sampled. And so then again, we draw from this heat map picture of everything. So every column is a date or a week, and every row is a school. And so I'm giving you 3 of these. So the SARS-CoV-2 is the blue and red, orange one. And then we have influenza A top on the right and RSV bottom on the right. And so you see similarities in outbreaks of RSV and flu across our cities, which is quite encouraging that we're really picking things up. And this is for last year. We've just started for this year. And so if we say, okay, now I have all this data, does it really tell me something? So we are able to statistically show that an increase in concentration of SARS-CoV-2 in the wastewater was associated with an increasing probability of a positive case at the school. And there was also a significant positive relationship between the aggregate SARS-CoV-2 wastewater concentrations of the school within the same zip code and zip code level positivity rates. So the statistics is solid here that we are able to pick up that signal. If we look at influenza A and RSV, so for influenza, we were able to detect the positive relationship. And so you see the plot with the uncertainty quantification. We have corrected these p-values for autocorrelation. That's critical for anybody doing analysis in this space. And so these are technically correct values. And but when we go to RSV, it's actually not significant. Part of it is impacted by the temporal correlation, but then also you see these 4 points. So this was when RSV was detected in the city, but it was not measured in the subset of schools that we chose to sample. So again, we're just sampling a subset of schools, but not schools across the city. And with that, I'll stop and turn it over to Dr. Persse.
Thank you, Dr. Ensor. All right, so first of all, I think you can see why I needed help presenting that material, because it's very complicated, but I think it's important to recognize that, with the talk that I'm about to give, part of my talk I'm going to give is that, all of this work has to then translate into something that's actionable and of value to the community. But in order for that to be the case, one of the things I've learned in public health over the years is that our currency is our credibility, right? Our single greatest tool in public health is public messaging. Well, probably secondary to vaccines over the years, but our credibility is incredibly important. So in order for us to have that credibility, this data has to be accurate. So there's a ton of work has to be done by really smart people like Dr. Stadler and Dr. Ensor and their team. So let me just go ahead and say, I'm going to talk a little bit about the public health actions and what we've done moving forward. So on this slide, so the data that is produced, so you just see how it got produced. It comes out weekly, and it comes out through some internal partners at the Houston Health Department on the left side of the screen, and then it's sent out externally to external partners. And I would wait for this information because, as we've pointed out, that it was on Friday that the analysis gets done. So come Friday evening, I'm often with bated breath, patiently waiting, and maybe sometimes not so patiently waiting, because there are people breathing down my neck wanting to know what the data is. And that's because it became an integral part, a really important tool for us as we move forward. So I'm going to be spending most of my time talking about how we interface with the people on the right side of this diagram. But before we do that, one of the things that we did to make this data available publicly is we put up this wastewater monitoring dashboard, which is publicly accessible. And we advertise it publicly through the media, but also like with a special engraved invitation to everyone in our community, our public health community, to make sure that they would be able to see this. And it went through like everything else. We were kind of inventing this wheel as we were, using it. And so this went through a couple of iterations as we went through time. And you'll see that on this, there's the map on the top, and each one of those wastewater, the wastewater treatment plants is indicated there with a colored circle. The color and the arrow indicate how things are changing. And those graphs that you saw a minute ago, or the change of the colors is what across time. So this is a recent snapshot. That's one week represented geographically. It's the same data. There it was represented longitudinally. Here's represented geographically at one time. Now, this is an interactive web page, and so you can go in, you can pick previous dates and go back and forth. So in this one, you can see the viral load was 73%. As a reminder, the units of measure that came from this analysis was I'm making this up, but it was like 1.4 times 10 to the 6 virons per cubic milliliter or whatever, right? And that means 0 to me, because when it changes from 1.6 times 10 to the 7th to 1.53 times 10 to the 4th, now is that more or is that less? You know, so what we did, what these very smart people here did, was they chose July the 6th, 2020, which is the peak of the first wave. And at that point, it was shortly after July the 6th, 2020, we looked back and said, okay, there was a peak. We made that 100% because that was the first wave. So surely that's going to be the worst one, right? And so we made that 100%, and everything else has been related to it. So on this slide, it says 73%. So that means that the viral load for the week that's represented here, which is what, October 9th, 2023, not too terribly long ago, was 73% in comparison to what we saw before. But you also saw on some of the slides how we've had multiple peaks. And sometimes we've been in the hundreds of percent, and we've been down as low as 20% at one point too. So that's how we translate it into usable information. And the bottom, you've seen the slide before. The green line is the viral load. The blue line is a positivity rate. And you also heard how we no longer have confidence in the positivity rate calculations because nobody's going to the public sites and reporting their data anymore. So what we get is less reliable. So we've just stopped reporting it. So that's why it says NA there. Now, since the beginning of the pandemic, we have been meeting with representatives from the healthcare community. In fact, in February of 2020, we had our first meeting. So it's called COVID-19 because it first came on the radar in 2019. Well, that was December of 2019. And you remember how quickly this thing moved along. So in February, we began meeting with folks from the Texas Medical Center, the CEOs, the executives, and we were meeting with them multiple times a week, and then it became weekly, and then we went into a viral environment. But this is where we built really strong bridges. And one of the important things is they became to recognize the reliability, the operational importance of the wastewater, because not only was it able to tell us that whether the current wave was decreasing and things were getting better, but it also told us if is this yours? Sorry. But it also told us, when the next wave was beginning. And it has reliably, this is really important, it reliably predicted 2 weeks in advance when hospitalizations would change. So when the wastewater started going up, hospitals knew that within about 2 weeks, the number of people being admitted to the hospital for COVID-19 infection and complications would start going. But that gave them 2 weeks to prepare. The other thing that was really operationally important was it gave them 2 weeks head notice on when their employees were going to start calling in sick because they were also infected. So if you run a hospital, that's obviously important. Guess what? If you run a food chain, employee absenteeism is important. If you run an oil company, if you run whatever business it is, these data became really important for them to pick up on. Now, the other thing is that as time has gone on, is was indicated, is that we have started testing for other things, right? Influenza and RSV in particular. So we've started a program where we're communicating with the schools, and you also saw that a lot of the schools now, dozens of schools, we are, through the manhole program, we are testing the wastewater from particular campuses, and therefore we're able to communicate to those campus administrators and school nurses, but we also make it available through that same interactive web page. You can also go in there and you can look at the school, the manhole results for the schools. So parents can look in there and find out if there is evidence that infection is, there is, whether it be COVID or influenza or RSV on those campuses as well. And so we've tried to promote that out. And here's a slide of one of our advertisements, trying to get that information out. We also push it. If you sign up, we will push you a text or an email. And here's an example. And I'm sure that's very easy for you all to read on the right side there. But in it, we talk about, what the results are, which direction things are moving. And if you sign up, so you can see there's a lot of information there, not only in what is the most recent result, but also what are some recommended things that you can do to protect yourself, your students, your family members. You can see there that as of earlier this month, there's 459 recipients, and most of them are school nurses, and about 200 citizens. So this could, we're kind of at the tail end of the pandemic, hopefully, right? Never say anything absolute in public health, but it looks like things are waning a little bit here. So I don't know that we're going to get a whole lot more folks advertising or picking up on this. Also, for those of you who want to write it down before I move to the next slide, there's a link. We did a a fireside chat, if you will. And we're going to do something similar to that here in a couple of minutes, where we discussed things. So that's myself and the director, Stephen Williams of the Houston Health Department, Dr. Jamie McCarthy, who's a vice president, and I forget his entire title from Memorial Hermann, and also Dr. Ed Septimus, who's actually world-renowned infectious disease expert. He's part of the Harvard faculty, and he's also works with some of the local health care systems here in Houston. And he's a nationally known infectious disease expert, just happens to live in our neighborhood. And so we sat down, we went over and we talked about a lot of things about how we made this, information practical for people to actually be able to use. And so if you want to visit that website, you can listen to and hear the entire discussion that we had. It's really interesting because Drs. McCarthy and Septimus were able to talk, and Director Williams talked a lot about the politics of it and how we were able to get things moving, but how this is really, really useful. And so with that, I understand I am out of time, and normally at this point I would ask for questions, but we're out of time. We're gonna have to move right into the next session. So what I'm gonna ask you to do, whether you're in the room or if you're online, and thank you to those of you who are online, we're gonna ask that you hold the questions until the end of the next moderated session, and we'll take questions then. And with that, I'm gonna thank Drs. Ensor and Stadler for not only for them taking the time to come today, but their expertise and their dedication. And I'm going to ask the panel from the next group if you'll come up forward, please. And the way we're going to work this is I'm going to briefly introduce each of our panelists, and then I'm going to ask them to actually give you the true introduction, but give you a little bit of their background. And then we've got some questions that I'm going to grill our panelists with. And okay. Well, okay. All right. And then we'll take questions from the audience. So with me here today, and thank you for everyone for being here, and I promise to try to make this not terribly painful, is Jennifer Deegan, the Honorable County Judge Trey Duhan, did I pronounce that right? Yeah. And Dr. Giordano and Dr. Mariana Mattis. Now, I think Frances Valdez was supposed to be with us. She's an attorney, the executive director for the Houston in Action, and she unfortunately is unable to join us today. But we'd like to thank her for having agreed to, and hopefully everything is going okay there. So with that, I'm going to transition over here, and everybody has a mic in front of you, and I don't know if it's turned on or not, but there should be a little green light. We're gonna go ahead and start off with some questions. Oh, let me just. Okay. So before I go, I just basically, gave very brief. I'd like for everyone to really introduce yourselves and tell us a little bit about who you are, where you come from, and why you are such a public health hero. Why don't we start here?
Sure. Hi, everyone. My name is Mariana Matus. I am co-founder and CEO of a startup called BioBot Analytics. We are a wastewater epidemiology startup, probably the first one in the world. And we were founded out of MIT back in 2017 with a vision to transform sewers into public health observatories. When we started working in the space of wastewater, it was unclear exactly how to, what data to collect and for whom, because at the time, this was 2017, there wasn't any large scale adoption of wastewater epidemiology in practice. So it took a lot of the kind of time to explore what was of interest. And we actually first started working on opioids, like substances and, the impact of these data to reduce overdoses. And then in early 2020, we began to work on the monitoring of SARS-CoV-2 via wastewater. Very early on, this was like February, March of 2020, when we first reported the detection of it in the wastewater from Boston. It's been a pleasure to be part of the larger wastewater epidemiology ecosystem here in the US. And we have had the fortune to now work across, I think, every state, and with stakeholders at the municipal, at the state, and at the federal level. And we love to be like in the press, talking to the media, evangelizing the use of wastewater. So yeah, did my PhD in the microbiome labs. That's how I got started in the space. And yeah, thank you all for being here.
Judge?
Good afternoon. My name is Trey Duhan. I'm the county judge for Waller County. I'm in my 9th year as county judge for Waller County. For those that don't know, I'm a constitutional county judge. What that is I'm elected countywide, and I preside over Commissioners Court with 4 other commissioners that are elected from their precincts. As a constitutional county judge, per the Texas Constitution, that also makes me the director of emergency management for anything that happens within my county. So that means when something goes on, Department of Emergency Management, TDEM comes in, and they will look to me as to the decision-making and what's going to happen. The only person that can overrule me in these kind of situations would be the governor of Texas. I didn't realize when I became county judge how much emergency management there would be in my role. Within the first 2 years, we had 4 to 5 floods, and 4 of them were FEMA level events, including Hurricane Harvey. Of course, since then, we've also had Arctic storms. And of course, we also went through COVID. So my job is, important from the standpoint of making sure that decisions get made and preparations get put in place for the health and safety of all of the individuals within my county. I appreciate the opportunity to be here. This is my 2nd year coming to this event, and I like being here because it reminds me how many more people are smarter than I am. Thank you.
Hi there. My name is Jennifer Deegan. I'm with the UT Health Houston, and probably the best way to introduce myself is to talk about what I'm not as opposed to what I am. I'm not a scientist or a clinician or a public health practitioner. My background's in public policy, primarily at the state level. And you heard Anthony talking earlier about this field of wastewater science and how it's being used and translated to support public health action. And that involves a variety of stakeholders from across disciplines. If that sounds familiar to you, policy development's very similar. And so I was put in my role with my involvement with TEFI and helping to figure out who needed to be at the table and how to have conversations around what should be reported, what data is actionable and meaningful for public health practitioners. And then phase 2 of that will be to address, as I think Dr. McGuire mentioned it earlier, and we're hoping to work together on this, kind of how do we communicate this to the public? How do we educate and engage the public and make sure that they're aware and involved and part of the decision-making process and how these data are reported? And I'm happy to be here today and appreciate all of you for attending.
Good afternoon, everyone. My name is Tom Giordano. I am a physician and researcher at Baylor College of Medicine. I'm professor of medicine there. I am a practicing clinician. I see patients in the Harris Health System, so in the HIV clinic at what used to be at Thomas Street, which is now moved. And when I round on the inpatient services, it's at Bentop Hospital. So I'm very familiar with the Harris Health System. I do research. Before COVID, my research was all focused on HIV, HIV health services research, and I have a VA affiliation that supports some of that research. I'm the director of a Center for AIDS Research that's called the Texas Center for AIDS Research. That is a collaboration of Baylor College of Medicine, UT Houston with all of its schools, and the Texas Biomedical Research Institute in San Antonio. And our focus is to try to end the HIV epidemic. But like most people, when COVID hit, I quickly became a COVID expert and had to understand what was going on with that and help, to some extent, the institution direct its policies. Baylor College of Medicine, that is, direct policies for COVID. So that's the hats that I wear are as clinician, researcher, mainly in HIV, section chief of infectious disease, so overseeing faculty at Baylor College of Medicine, and involved in institutional responses.
Great. So first of all, let me just thank everyone for coming, because obviously we've got a brain trust here of smart and experienced people. And you can also see we've got a pretty broad background of folks to ask questions of here. So I'm going to dive into our question. The first one, Dr. Mattis, is for you. So you test for wastewater. And, we spend a lot of time, we just now, when this you know, in our previous hour, talked a lot about COVID, but we also touched on the fact that in wastewater, we can identify other pathogens. What is it that happens when you get a result for something you didn't expect? For example, measles, or like in New York City when they found polio, right? That in New York, they had a patient, and then they looked at the wastewater and said, oh my gosh, there's polio in the wastewater, right? So what do you do when you find something you hadn't expected in the wastewater?
Yeah, that's a great question. So at the moment, we are testing like via targeted methods, like a number of pathogens. So we're not yet doing more agnostic work to try to, you know, to be surprised by the detection of a pathogen we didn't expect. But some of the pathogens that we follow and targets are rare. So we have some experience on that space. So one of the pathogens that has been largely like undetectable or like rare has been Mpox or monkeypox, like the outbreaks that have happened over the past 18 months or so have been kind of just more constrained to certain parts of the country. So most of the times what our partners receive is a negative result. And therefore, we learned pretty quickly that if something that has been negative suddenly turns positive, there's going to be a very high need for support of that partner because they need to prepare to communicate it out to their healthcare system as well as to the citizens. So that I will say it really it necessitated us to develop almost like an SOP for what review needs to happen internally and then with a partner in order to make sure that the communication is correct, make sure there are no mistakes.
Right.
What you wouldn't want is that, you know, a rare pathogen gets detected and it's actually, for example, a false positive that causes a response that was not needed. So there needs a high level of confidence is needed in all of your internal as well as external SOPs. And something that we have seen as well is that it is applicable not just for pathogens, but also for emerging substances. So like psilocin is an emerging substance of concern in the US. President Biden declared it so earlier this year. And we also have been detecting it in some communities. And the first detection for one specific community in California, Marin County, they also put out their health advisories to the hospitals as well as to the citizens. So I think that probably that's the first step, just like the communication to more people outside of the wastewater testers and the direct point of contact.
So I'm gonna ask you a question. So when you introduced yourself, you said you were I believe you said you were basically the first commercial wastewater. I mean, I assume when you said first that there are now others, and you know, shame on them, right? Because you should be the only. But anyways, okay, copycats are allowed. But I'm assuming, and I'm asking this question kind of completely naive. I'm assuming that you contract with communities, like you mentioned, Marin County. So your customers are going to be governmental, local governments, or state governments, or whatever. And there are more people. There are more companies like yours that are coming out of the screen. Right? So that's interesting because, you know, I mean, we haven't got enough time, but I got like a half a dozen other questions I want to ask you about that, but I'll move on. But that's really fascinating to see that the private sector is now picked up on wastewater. And that's good because this is obviously something important and beneficial. All right, so Judge, I'm going to ask you the second question because I suspect there are, you know, I think that as a politician, as an elected official, you have to, whether you've got a degree in it or not, you're a bit of a sociologist and you understand how people, or you have an insight as to how people are going to behave during certain stressors, right? So now that wastewater is probably going to become something that's going to be with us, wastewater testing, how do you think that the community will respond when we start seeing things like, whether it be measles or polio or flu or so on and so forth? Do you think, and I don't mean to ask to pin you down, but amongst elected officials across the nation, or at least across Texas, is this something that you see elected officials buying into? Do you see them using it? And how do you think the public's going to respond? Because we're going to get something like, you know, we're heading into flu season, right? Nobody's going to be surprised by that. But, you know, RSV is something that I think, quite honestly, I think until the recent vaccines came out and we started seeing all these ads on TV, I think a lot of the people in the general public had no idea what RSV was until either they or their child or somebody was infected with it. So anyways, just from the standpoint of the public interface with wastewater and what we're learning, what comments do you have? What insights do you have for us about that?
Well, when it comes to these kind of things, obviously communication is essential, and effective communication can only happen if there's a level of trust between the person communicating and the person receiving it. So in my role, one of the things that I have to do, if I'm going to be effective as the director of emergency management, if I'm going to expect to put information out there and hope that people make good decisions and change their behavior for the benefit of their health and welfare, then I have to have built that trust up between myself and those individuals. And that's something that is done over time. Now, when you're talking about something like this, I think it becomes even more important, because for people to accept it, not only does it have to come from somebody they trust, but it also has to be broken down on a level that they can understand as well. So taking something like this and then putting it, into words or terms that can be understood by, the everyday person is going to be essential. So not only do they understand it, but it's coming from somebody they trust, and then they can use that information and they'll use it effectively. I think that this is, I think any politician or elected official that's in a role such as mine would be remiss if they didn't use this kind of information when it came to making decisions, or at least communicating what's going on out there to their community. In a way, I think because time is essential, and the more lead time you have to prepare or anticipate is huge. And I was thinking about this earlier, if you think back, to make an analogy, and one of the things we do, of course, is when we have weather events, and you think before we had Doppler radar, you pretty much knew if you had a tornado when somebody spotted one coming down and touching on the ground. But then Doppler radar comes along, and now when the wind and everything's in place to create a tornado. You have that much more time to give warnings and tell people to seek shelter. And then that enables them to make decisions that could possibly save lives. So that, to me, this is the Doppler radar of epidemiology. If I got that word right. So I think it's highly important, because time really matters. And knowing that there's a surge, that things are starting to come up, and enabling people to maybe make better decisions, giving them good, reliable information, and doing it in a way from a source that they trust, and then understanding why that information or how that you got that information, it could make a huge difference in saving lives.
The irony of it, and I really appreciate what you said. The irony of it, is that if we get this notice that there's a pathogen in the community, let's say it's measles, right? So we detect measles in the wastewater, and we get the messaging out, and we are successful, and people do everything we ask, and the measles loses that battle. In the aftermath, people say, I don't know what they got so excited about. That they said there's gonna be a measles outbreak. There never was one. And it's like, I'm not listening to them next time around. It's so, you become a victim of your own success.
Right.
If you're really successful. So I don't have an answer to that, but this is why I don't run for office.
Right. No, it is a challenge. There's no doubt, because and we even saw that during COVID and so forth, when people said, see, the levels are not as bad. And it's like, yeah, but people are also doing things different than the way they did them before.
Yeah.
So yeah, you can sometimes it can be a self-fulfilling prophecy, or you be a victim of the success. But at the end of the day, you got to put the information out there, and then it's up to individuals to make those decisions for themselves. I'm proud of the fact, one of the things I used to say, during COVID, Waller County actually had one of the lower infection rates of all the metropolitan counties around Houston, and one of the lowest fatality rates. I would love to take credit for that. I think it probably has more to do with what I joke around, that Waller County invented social distancing. We have a little bit more space out in Waller County, but that's now changing as well. A lot more people heading our way. But yeah, you have an obligation to put the information out there, and then people really got to make those decisions. But as long as it's good, accurate information, then that's all you can do.
Yeah. All right. Thank you. All right. So Ms. Deegan, I got a question where you're in the policy sphere, which, by the way, everyone, that is a really difficult level of the atmosphere to work in. So kudos to you for doing that. How do you think we talk about the potential with wastewater for testing pathogens, biological, but there's also things like, drugs, and there will be other things in the future. So what can you tell us about what you think communities are going to find acceptable to be tested in the wastewater?
Yes, I'm going to answer that in a couple different ways, and ramble a little bit at first and echo what some of the other folks have said, and that is building a successful wastewater monitoring program is going to depend on building public trust. And I think we know that. And if the science gets too far ahead, our communication with the public, that's where you run into problems. And I think right now what you have is any community that is testing wastewater. I heard how Houston is deciding with a panel of infectious disease experts. There's probably that many different ways of determining what you're testing for in wastewater. And one of the things we did early on with TEFI is we've partnered with the Center for Health Communication at UT Austin Moody School of Communications, and they conduct a national survey every year on different public health topics. And this year they added some questions around wastewater that I think speak a little bit to your question. And this goes back to the idea too, that there's different levels of support based on what the purpose is and also how much folks know about capabilities of wastewater monitoring. And so what we learned is there's pretty low levels of understanding or awareness of the use of wastewater as a public health surveillance tool. But there was generally more support for it than for using it to detect, for example, the prevalence of illegal substance use. And I understand because there's concerns that were alluded to about interactions with law enforcement and things like that need to be sorted out. But I think generally there was a relatively high level of support for using this as a public health tool and for clinicians to be able to use it to prepare and respond to infectious disease outbreaks. And we need to do more work and more community engagement, but that at least kind of gives you a snapshot of where the general public is on this.
Okay. Thank you. Dr. Giordano, with wastewater, we're anticipating, I used the example of measles a couple minutes ago, and we're looking for RSV and stuff, but how do you see clinicians, well, I guess this is a two-level question from my standpoint. One is, do you think that clinicians in the community have grasped the concept, basically even just the concept of wastewater monitoring? And then once we start getting results, let's say we get a measles on the radar or polio or whatever, how do you think that the clinicians across the community are going to use that information? So two-part, have they bought into it? And then if yes, how do you think they would use that information?
The first part of the question is really hard for me to answer. There's a common perception among the general public that physicians are somehow a universal monolithic body, but we're all siloed. Yeah. We're all in different institutions. I'm an infectious disease doctor. You're an ER doctor. There's cardiologists, there's dermatologists, there's surgeons. I don't talk to those people. and
I don't talk to people from Michigan. So good.
Right. Unless I'm rounding at the hospital, and then sometimes we're doing battle over different antibiotics. But the point is that each physician is an independent actor in many ways, and so whether they're using the wastewater, I don't know. But I can tell you that among the people I talk to, the wastewater is highly regarded and now seen as the only reliable indicator of what's happening with COVID. Because everything else there's no more reporting. For about 3 years, every morning I got a report from Bentob, the VA, and Baylor St. Luke's, the 3 adult hospitals that are part of the Baylor system in the med center, on how many people had COVID in the hospital at that morning. And we saw the same curves as everyone else, but it was really useful to know what was going to happen. We stopped doing that a long time ago. So the point is, the physicians that I talk to do seem to trust the wastewater and rely on it now in the ID community, but it's hard for me to speak beyond that. And that gets to the point of the second question, like what if we do see measles in the wastewater? What's going to happen? How will people use that? At the individual physician level, I'd like to say that, well, it's going to change your pretest probability. You see a patient who has symptoms that could be a rash, that could be measles. I've never seen measles in real life, and probably most infectious disease physicians, most physicians in practice in the US now have never seen measles in real life. So without some indication that I should be aware of it and alerted to it, I'm going to miss it. So if there's some signal that says measles may be in Houston, it's going to really raise my pretest probability, my awareness of it, and I'm going to think measles when a month ago it would not have crossed my mind. So there's that. That's real, tangible potential benefit. The other thing is just alerting people. This requires some more work, I think. Like, how does this system of wastewater monitoring get information to all the physicians? Again, I'm in an ID. I follow the wastewater map. I know exactly where it's bookmarked on my computer. I know what's happening. But does a cardiologist? No. And even during the height of the pandemic, I would give monthly updates to the Department of Medicine about what's happening in COVID, and everyone would say, that was great, so helpful to know what's going on. I'm like, how are you not following this every day? We're in the height of the pandemic. But they aren't, because they have day jobs. So communicating that, we need a better system to alert all physicians. The Houston area network alerts are great, but I don't know who's registered for those. There has to be a better way to alert people so that physicians have the information that they can then use when the system triggers for something. And then in terms of how we would use that, I think would be better informing our patients what's going on, vaccination campaigns. Obviously, there's a lot of public health information or public health actions that could be taken. But to me, the critical issue is getting the information into the people's hands that are actually going to be acting on it, the clinicians' hands that are going to act on it. That last step we haven't done yet. We are closer now than ever before because of COVID. I mean, COVID taught all of us to look for silver linings and things. And one of the greatest silver linings of COVID, I think, is this whole conference is really showing us the academic, public health, public authority, government coming together in a way that never happened before in most of the United States, and certainly, to my knowledge, in the Houston area. So that is a great thing, and we need to keep that momentum going. But we have to figure out ways to actually inform physicians of things that they're not looking for.
Yeah, I'm going to follow up on two things you said. One is he referenced the HAN, the Health Alert Network. So this is a national notification system that's really based out of the CDC, but locally, the Harris County Public Health is our local administrator for that. And so I don't have the webpage, but if you just Google, Harris County Public Health or Health Alert Network, you can sign up. It's free. And everything that is new and changing that a clinician might want to know about will come to you. And so it's widely used, but I think, to echo your point, I think it's underused. So if we have, it'll tell you about new pathogens on the horizon. It'll also tell you, if there's a rabies case in anywhere but Waller County, because it would never happen there. But things that would otherwise would be important potentially, but completely off your radar. So they filter it really well. So there's not junk. You're not going to get junk. You're going to get important stuff. And it's the Health Alert Network, and it's available to anyone. All you have to do is sign up for it. And then the other thing that you said, I want to find, so every Monday, because the results come in on Friday, and generally over the weekend, I've noticed there's a little bit of polishing that goes on, because between Friday and Sunday, when I get another notice, sometimes the number changes a little bit. But on Monday mornings, I'm still texting the CEOs and of all the major healthcare systems with the most recent positivity rate. I used to give them not positive, of the wastewater percentage. I used to give them that and the positivity rate. We just recently stopped the positivity, but they're still getting it. So I'm a little hurt, quite honestly, to hear that you're not getting that anymore.
Oh no, I never got it from you. I look on the website. I just
no. But you said that for a while you were getting it from the hospitals. We're getting it to you. Yeah. So I'm imagining that I'm getting it to them before it's on the website, and then they were distributing it to you. And so now I'm feeling that they're not getting. So
No. What I'm not doing anymore is getting the hospitalization data.
Oh,
not the way that was getting burdensome, and there was little utility to it anymore.
Yeah.
The issue with the most recent waves has been the staffing issues, not the patient volume in the hospitals.
Yeah,
it's been the nurses and physicians and residents out sick. That's the impact.
Yeah, right. And we've had a nursing shortage in this community for quite some time, but then when you add on COVID to it, it made it even worse, right? So okay, so my feelings aren't hurt anymore. No. All right. So the next question really, Judge, is for you and I, and it really has to do with with the wastewater surveillance and, how it would impact our existing processes for community level emergency planning. Years ago, before the pandemic, we spent a lot of time locally here in Houston, city of Houston, along with Harris County, about pandemic flu planning because it was time. We were due for another pandemic flu when we went through this whole big, very controversial process of crisis standards of care. And what that basically, to make it easy for you, what this came down to is you're the doctor working in the emergency department. You've got two patients in front of you. Both of them need to be put on a ventilator. One is 75 years old with heart disease, hypertension, and stage or type 2 diabetes, and the other is a 7-year-old. Who gets the ventilator? The 7-year-old got there 10 minutes before the 7-year-old. Who gets it? And so I think a lot of us sort of knee jerk would say, well, the 7-year-old, right? Except for the family of the 75-year-old, right? So we went through this. So anyways, with wastewater, giving us a heads up on what's coming from you are the emergency manager. Congratulations for Waller County. Is this gonna, what do you thoughts you have from that sort of standpoint, from the standpoint of the emergency manager for the county? Does this become part of the equation for you?
Oh, absolutely, because it definitely expedites things. It's going to move things along faster, especially if we know something's coming. There's going to be a surge, or we know whether it's COVID or some other disease is on the horizon, and there's things that we can do. Emergency management is preparation and being prepared for that emergency and having a plan. We do that. We are constantly updating our plan, our processes, so that when an emergency occurs, it's just a matter of putting that plan into motion. Mm-hmm. So the more notice that we have, the more that we can anticipate something is about to happen, then the better we can be prepared and have the things in place to respond and deal with it, whatever that might be. Again, and during COVID, I would do the same thing every morning. I'd look at all the data coming out of the medical center with the surgeons and stuff, but having, lead time on that, knowing a week, 2 weeks ahead of time is even better. Because then we can take other steps and make sure we have the right things in place. And I actually, one of the benefits is having a good relationship between government and the medical community. And I see Dr. Placencia over here, who is our health officer from Texas Department of Health Services. And prior to all of that, I didn't even know who my health authority was, to be honest. And now we have a very tight relationship. And when the phone rings, I'm like, uh-oh, what? Dr. Placencia is calling, something's about to happen. But having that kind of relationship and communication, and then having the kind of data that, again, it's reliable and it's accurate. I have to base decisions. The decisions I make can affect, lives. It can, whether it's evacuating somebody because we think that their area is going to flood, or deciding to close something down, or telling people what they can, those are very hard decisions. They're not easy to make, because sometimes you get put in a situation where no matter what you do, you're going to get criticized one way or the other, and livelihoods could be impacted. And we saw that during COVID. We had folks in Waller County that, when we decided to close, bars and restaurants and stuff, and it's a small mom and pop restaurant, their livelihood was on the line. Mm-hmm. So I have to have accurate and reliable information to make those decisions. And the more lead time I have, the more advance notice I have in making that kind of decision and telling people to prepare, and having that is just essential. I can't emphasize enough how critical that is in any kind of emergency planning scenario, is having as much time as you can to prepare.
Thank you. Ms. Mans, I have a question for you. You come to us with how the private sector is moved into what, in many regards, historically has been an academic and governmental space, and there's space available. So good. So thank you. But my question is, as we move forward, what do you see the private sector? There's yourself. You mentioned that there are some unfortunate competitors to you. We have we feel bad about that. But this is, remember, the wastewater is just one part, right? There's this, the response, it goes from policy and planning all the way to the clinician, at the bedside, taking care of the patient. So I don't know if this is an unfair question, but do you see the private sector being able to insert itself in other areas beyond just wastewater testing? So that's a pretty broad question, which you did not know was coming, but you're from the private sector, and I'm sure you go to the conferences, and I'm wondering if there is talk of where people are making, inroads into the other parts of the links in this chain.
Yeah, no, I think it's a great question. I think in general, the space is very emerging. And as we have seen already, it definitely necessitates collaboration from many different types of stakeholders, different types of government agencies, innovation coming out of universities. And then I do think that there's a big role for the private sector to help as well. I don't think that the private sector can solve or really do all of the work on their own. I do think that we need to be part of this ecosystem. And who does what, in my opinion, is still a little bit evolving. Historically, where we have brought value, for example, is in basically just having somebody full-time managing and designing wastewater programs, because that can become a full-time activity. And then kind of where does that leave, right? Who does that? So historically, we've brought a lot of value there. As I mentioned, we have been creating data from across the nation. So I think there's been some unique learnings about the ability to work across different states, just different types of wastewater, different philosophies about what the wastewater is useful for, different political affiliations, right? There's just been so much learning about the ability to think about it more as a nationwide and eventually, hopefully, more than one nation, because as a world, we're united as a one health. So I think there's a lot of opportunity to actually connect even jurisdictions doing the work and create more of that national and eventually again beyond national, almost network. So that's been where we're trying to position ourselves. And there's going to be programs, for example, what we have here in Houston, or what there's in other parts of the country that are just so mature, as developed locally, that again, maybe our role is more about connectivity to the rest of the country, or, there's other value props because so many of the pieces are kind of already covered here. And there's going to be states and cities that actually don't really have that expertise, that infrastructure, and it would be very difficult for them to get all the pieces in place.
So I'm glad you said it, because that leads me into my next question for Ms. Deegan. It's a policy question. So we want to make sure that there's equity, right? And this is sort of a high level question, but here in the city of Houston, we've got every neighborhood in the city of Houston has got wastewater testing available to it. I can tell you from our experience is that when we had increasing values of COVID in underprivileged, economically disadvantaged neighborhoods, we the Houston Health Department, we put teams together, we went into those neighborhoods and started, taking action. But as you just pointed out, is that there are communities that may not have wastewater. So at a high level, and I'm, again, maybe an unfair question, I'm here with UT Health, you're not with the federal government, but and UT Health is huge and wonderful, but it doesn't, but the point is, in terms of equity moving forward as a nation, do you have any thoughts on how we make sure that all neighborhoods can have access to wastewater monitoring? Because we've seen the utility with COVID, but I really worry a lot about the next unanticipated pathogen, right? And to the judge's point, if we get caught blindsided, we're weeks behind the curve. Yeah.
I think that's a really important question. I don't have a great, easy answer to it. As you might imagine, equity is clearly an important issue. I do think this is a role, at least for Texas, where TEFI could play an important role because, we have been funded to do this. The goal is to reach out statewide. And so we are working with communities that maybe don't have the Texas Medical Center in the middle of them. And so that's helpful. I think the other piece, and I said this before, we have to do more here. We have to be guided by communities and what they want and need and what they're comfortable with. And we're seeing with TEFI as we move across diverse communities in the states that there are different concerns that different communities have. And just one example we've heard from some communities, like, how are you going to use these data? Are you going to use these to shut down businesses and schools? And I don't want, as the head of my utility or the county judge or the mayor, to be responsible for that. And so one of the things we've talked a lot about, and we know that those kind of decisions disproportionately often impact more vulnerable populations. And so we have to be very careful about how those decisions are made. And one of the things that I think wastewater offers is, as Dr. Gerba alluded to earlier, sometimes having some advance notice and more information helps you keep things open and running and functional safely, and it saves you money in the long run. So yeah, we want all communities to have access to it, because on either side, either whether you're disproportionately affected by a pathogen and the impact of an infectious disease outbreak, or by the economic and social consequences of mitigating actions that the public health community has to take, either way, you want everyone to have a fair shake.
Okay. Dr. Giordano, I was reading your body language. You're chomping at the bit even before you put your hand up. As I was asking the question, he doesn't know it. His lips started moving. So I know you've got something to add.
No, I do. So I think this equity issue is obviously very, very important. To me, the fact that there are wastewater samples available from urban centers, and then there's large parts of the state that are not going to have any wastewater monitoring. They're just not, because of they don't have treatment facilities. I think there's a gap. There's an obvious gap there. Fortunately, I do think that most of the pathogens that there's two kinds of pathogens that we're going to face, whatever they may be. One are going to be imported. There's going to be an outbreak of something in Africa or in Europe or in Asia that's going to come, just like SARS-CoV-2 or monkeypox or Mpox did. It was imported into Houston. You're going to see that in the wastewater because that's where most of the people are, and it's going to be where the more travelers are, and so on. So I think wastewater is ideal for that. It's less ideal, though, if there's no wastewater, if you're worried about the zoonotic infections that are going to come off the farm, the bird flu or the swine flu that's going to start somewhere else. Wastewater is not set up for that until it gets into the Houston stream. And so there's a blind spot there that we have not been able, that this won't address. And I don't know how to fix that.
I've never heard it put that way, but you're absolutely right. I'm going to remember that perspective.
Just footnote me.
Yeah. Okay. Yeah.
I think on the topic of equity, I think it's just so important to keep it front and center for the space of wastewater monitoring, because this technology starts, I think, as we saw it in one of the slides of Anthony in the morning, like, we're all contributing to it. We're like, a little bit of us is in those samples. And I think, just to me, the thought that there will be maybe cities or counties that don't have the expertise or the money to do the work, and that they won't be able to benefit as other areas, to me, that's just like really shitty, pardon the pun, but I just feel like it just really goes against like the whole purpose of the space of making public health data more equitable. But yeah, I think that, and there needs to be more effort and investment as to how to bring the monitoring technologies to those areas and make sure that the data is used like locally. Right?
Well, I'll tell you one thing that I think so in a moment here, we're going to move to questions from the audience, both in the room and online. So if anybody wants to formulate their questions, do it now. But I want to just say that I think I'm looking to the private sector to help us, because, as we started this here in Houston, we were able to do it because we got some grant funding and we got creative and so on and so on. But it is not it hasn't been really an incredibly inexpensive thing to do, right? So you got to buy these devices that go into the manholes or go into the wastewater treatment plants, and they sample the water and they keep it cold, and they take a sample every hour, 24 hours a day. You got to have people who are willing to go down in there, and they're going. Think about it. They know that they're going into an environment where there's all kinds of bacteria and viruses and parasites to retrieve this thing and pull it out for you, right? And then you've got to bring it to a lab where there are really smart people using really high-tech equipment with something which is potentially really dangerous. So it's not cheap, right? But the private sector is good at refining processes and making them less and less expensive while maintaining the accuracy, of course, right? And that will help with some of the equity issue in terms of getting this out into smaller communities where they may not have as much, money to pay for it. So as the cost of the operation comes down, then we'll be able to help a little bit with the equity issue and with that. So I just wanted to, put a little weight on your shoulders and make you have homework to do. So, all right. So with that, can we turn to questions in the room? And I think we're going to have a microphone. First, we'll go to questions in the room. So if everybody has a question for the panel, raise your hand. We have a question right here in the front. We got 3 questions up here. And also, I'm going to look to the back. Do we have questions coming in from online? We do? Okay. All right. Yes, sir. Why don't you just state your name and
Yes,
ask your question.
good evening, sir. Thank you so much for your time and all those important information that you're sharing with us today. My name is Ron Bhattacharjee. I'm from Houston Health. I have a question for Mariana. Since you started new company, my question to you, what are the major concern in the wastewater treatment industry?
So the main concerns from the wastewater treatment plants, if I understood?
Yes.
Yeah, okay. So some of the concerns that they have are that, the added labor and work, the added effort that they have to put into collecting those samples for the programs. And this is getting worse over time because now there's more and more stakeholders asking for samples, right? There's usually by now wastewater treatment plants have many requests on the table to participate and send samples to different programs that are being operated, at a federal level, at a state level, at a local level. It's a research project in the university, right? It's getting like out of hand and like just adding a lot of effort for them. So they are even trying to create like frameworks as to how they decide what they have to do or not, and like what they are allowed to do or not. In the beginning of the pandemic, they used to pay actually for the work, but that was very temporary, right? Just because public health departments were very busy with the response of the pandemic. So many wastewater treatment plants actually stepped up to cover the work. They should not be paying for this work going forward. There are concerns about just how the data will be used indeed, and they want to know, where is this data going? I want to make sure that it's being used for something, that my effort is worth my time. So I think like those are like the main concerns that in the beginning of the pandemic, they also were very concerned about potentially getting infected through their work. So there was a lot of communication to try to explain that there was no evidence about infectivity of SARS-CoV-2 via the wastewater. I mean, obviously there are so many other potential things that can make them sick. So I think many plants, even operators, became even a bit more aware that they should be using PPE for their work because many of them actually don't receive any training and they just are getting exposed to it, and they have all these stories about, cancer rates and, things like that. That is almost like lore in the community. And I think like they picked up more information like, oh, maybe I should use gloves and, things like that, because maybe I won't get COVID, but there's actually many other things that I can get. So I think it's a very important community for sure to keep in mind.
Hi, Roger Seeley, also with Houston Health Department. So I'm thinking about sustainability of these programs, and Dr. Persse had mentioned the cost. And right now, this work is fairly well funded at the federal level, but that might not always be the case. Do you have any tips for advocating at the state and the local level for funding as kind of like infrastructure when you know you're going to be competing against fire, police, and other traditional infrastructure in the same budget?
Are you directing that question towards anyone in particular?
Well, I think it's like anything else. It has to be prioritized, and I think it should be probably on the same level as first responding units, your fire and stuff, which then basically I think is going to probably put the burden a lot on your local government. So that if there's not federal funding coming through and you need that data, you want that kind of data, then you're going to have to basically provide that through your general revenue fund, or, and that's going to obviously affect your tax rate to some extent. But the question then becomes, how big of a priority is it that you're going to, incur that burden? I mean, obviously we have the ability, you don't hear too many governments going bankrupt because we have, we collect property taxes, and, whether you like it or not, I pay property taxes. I don't care for it very much, but that's our source of revenue. So at the end of the day, I've got to make sure essential services are provided, and we know what our budget is. And then we have to go in and we basically set a tax rate so that we can accomplish and deliver those services. So to me, it's essential. And if it gets down to the local level, it would be nice to see the state come in and provide those kind of revenues, because that's typically the state likes to pass everything down to the local level. They love to pass laws that require us to spend money, but they don't like to give us the money to actually do it. It's called unfunded mandates, if you've never heard of that before. I'm not a fan, but and then it puts the burden on the local folks to have to come up with the money one way or the other. But if that's what you have to do, and it's important enough, then you'll find a way to do it.
I'm gonna add a little something to that answer, and that is that I'm not an elected official, but I've worked in local government for quite a while now, and I've learned a couple of things. One is that the public is always very supportive of things for public safety, for law enforcement, for fire, for EMS. They're very supportive of that. They're also very supportive of things for like libraries and parks. And if you pay attention to things like city council, and when people come to talk, it's largely, not exclusively certainly, but it's largely retired folks and parents of school-aged children who want libraries and parks. And a lot of people, a lot of politicians will campaign on public safety issues. So I fear that if wastewater becomes something where the funding gets pushed down to the local level, it's going to be really difficult, because, well, you're right, it is a public safety, part of public safety. There are no TV shows. There's not, there's Chicago PD, Chicago Fire. I don't remember seeing Chicago Public Health wastewater. And I don't think I think that pilot didn't get very far. So, but it's also the sort of thing where if something happens, those same members of the public will turn around and scream at the politicians, well, why didn't you have this? So local politicians are in a very difficult situation when it comes to something like this. So I just want to add that perspective to your question. The funding is important, but it's not just as simple as, the feds will pay for it, or the state will pay for it, or the locals pay for it. It actually becomes quite complex as to how you figure out who's going to pay for it today and tomorrow. And just like we said earlier, ideally, we will go a long time without it showing us anything. That's what we hope for. But as soon as it does, and you missed it, you're in deep trouble. All right, we got one more question from the room, and then I know we've got one waiting online.
This will be initially for Mariana, but it really is for everyone. Pedro Antonio Piedra from Baylor College of Medicine. And it starts with something that you stated before about false positive results. Here, we are always getting negative results for the most part, and all of a sudden you get a hit. And you have pressure upon you, you have timeliness and credibility. So how do you go to a potentially false positive result to validate whether it's a true or not? How much time do you take before you start to say this is a true test?
Yeah, thank you for the question. And we actually experienced that with a community. So I can really share kind of what the learning was. And what we learned is if there is a target in this case, it was an mpox result that is really like negative, like just you have never seen it appear in a location. And then suddenly you see a detection that it merits like a special type of flag for the team to repeat it and make sure that it's a true positive. So basically you would be rerunning your tests on basically doing a new test on the sample to make sure that it's a real positive. And given that we're right now talking about PCR technologies, that actually only takes maybe another few hours. This is not really any meaningful delay in getting a communication out, but it really protects you from communicating something prematurely. And fortunately, in our case, it's only happened once, but it definitely changed our protocols as to how we report out, again, these like very rare pathogens to make sure that we don't communicate the wrong message out there, because then the public really loses trust. And we cannot afford that, right? Like people have been saying over and over again, the importance of trust. So all I can say is that in that case, just being very transparent with everybody through the process helped to reestablish some trust, as well as to indicate how the process was going to change going forward to make sure it doesn't happen again. But fortunately, again, given the timelines, you can really do another test and get a confirmation to make sure it's like real ahead of communicating something so grave.
I'm going to add a little something to that. And I'm looking at Kirsten Short, who's sitting here, who's our head of epidemiology. And she and I have worked together for enough decades now, really, that when you get a result that you don't expect, not only do you go through and make sure that there's no, laboratory contamination, blah, 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 all the checks and balances, and you run the test again sometimes, but then you still need to put that test result in the context of the community and what is going on in the community. And depending on what you're talking about, that can sway you one way or the other, because there are some things where if you say, okay, we think this is real, that sets off a set of dominoes that are huge and highly impactful to the community. So let's say we here in the city of Houston, we thought we had something. Let's say we had a reason to think that we had been attacked by some bad guys with anthrax or something. Well, we're talking about shutting down the freeways. You're talking about shutting down the airport. You're talking about stopping rail traffic. If we really think that somebody attacked the city of Houston with anthrax, like what happened in DC, let's say it was more, just as an example. So when you get a test result, not only do you have to make sure that the science is right, but then you got to put in the context of the rest of what's going on at that time, because the consequences are huge in either direction if you decide wrong, right? So if you decide that this is real and you set all those dominoes in motion, and it turns out that you were wrong, that's, I don't have to explain it. Conversely, this gets back to something the judge was pointing out earlier, is if you say, nah, I don't think so, and the next day, not only do you get the same result, but now you got it in 15 different wastewater treatment plants, you've now lost a day when you only, and if it's let's say it's something which is, which we would respond to with widespread antibiotic distribution, you've now put yourself a full day behind, what's probably going to take, 4 days, and you got to get it on board within 4 days of infection or something like that, right? You've lost a day. It's not, that is a really complex situation. You raised a great question. The rest of the panel, anybody want to add? Because you did say you wanted to ask everyone, but.
I just wanted to add that you're articulating one of the principal concerns we heard from local public health officials when we first started discussing developing protocols and notification protocols around findings from wastewater, and particularly when it comes to I'll use a non-scientific term, like really scary viruses or things, because detecting something like Ebola, say, that you should not be seeing in the wastewater, theoretically sets you up for a whole string of interventions that are costly and very high profile. And so I just wanted to say we've heard that over and over from local public health departments, and the caution that we be sure that we're validating those scientific findings in every way possible before we're asking them to take action.
I would just say that anybody who wants to go into public health, you need to enter into it. If you're going to do it at the level of a decision maker, you have to enter into it with an idea that someday you're going to wake up and you're going to be confronted with the problem. And in your heart of hearts, you're going to make a decision you think is right. And you may be you may be unemployed by the end of the week. And that's just the way it is, right? I mean, and that doesn't mean you did anything wrong. It just meant that if you lose your job over that, that means the community did okay. Right? And I'll take that one. So anyways, Dr. Giordano, you're
Just a quick comment to make this even more complicated. Ebola should never be in Houston. Anthrax spores, Bacillus anthracis, they exist in Texas.
Yeah.
They're in the environment. So that's another thing you've got to work
That's the
through,
context, yeah.
depending on the,
Yeah,
it's all context.
I remember that New York Times article about finding anthrax in the New York subway like a few years ago, and it was analysis done via the microbiome analysis of the subway. And as you say, it was no need for like that emergency reaction, but can happen with, especially when targets where it's unclear kind of the source.
Okay. So Kirsten, I see your hands up, but I said we go to there's an online question, and then if somebody could get Ms. Short a microphone. But we have an online question?
We do, from the online folks. I appreciate how the Houston program has become to increase the breadth of pathogens tested. Is there a mechanism to evaluate pilot programs for testing other pathogens in collaboration with other Texas public health partners?
Dr. Ensor Stadler, do you want to take a crack at that? We did say you were fair game for these questions. You do remember that, right? Hang on, they're bringing a mic to you so the people online can hear your answer.
Expand to other pathogens. Expand to other pathogens.
So we do actively look for other pathogens, and as we said, guided by the infectious disease doctors panel, we try to share all the information that we have. And if you go to our website, we put more out there just as much as we can, as quickly as we can. And that includes code for the analysis. And so I think in terms of sharing across, I'm going to turn this over to Stadler, but in terms of sharing across other health departments, that would go to Dr. Hopkins and Dr. Persse to carry that baton.
Did you see the play she just made there? Did you see that?
I was just going to add, I think there's a lot of opportunity to integrate the agnostic and the targeted methods much more deliberately, where you have these agnostic methods that are screening for everything. They're extremely comprehensive, and then you pair them with much more targeted assays that usually are a bit more sensitive and faster to turn around and cheaper. And so I think as we think about new pathogens, we might think about, okay, yeah, what are the baseline levels? What are we seeing in the wastewater? Can we learn anything from the agnostic screening to say, oh, look, there's some things that might be of concern here that we want to get more routine baseline data for at specific locations. And then in Houston, we would go to our advisory board probably and say, like, these are what we're thinking about. We need a framework by which we decide where to implement these things and how frequently, and how that information is going to be used if we do detect it or get baseline levels and it changes.
Okay.
Let me make one other point that, we are the CDC Center of Excellence. And so what that means is that means a lot of things, but one, we're working really hard, but two, the health department staff are integrated into all of the efforts that the CDC have underway. And so there's a strong communication between what we do in Houston, and it gets spread nationally pretty quickly through that mechanism. Is that fair? Okay.
And with that, we are out of time, and I know we have at least one more question, but I'd like to thank Teffy, and I'd like to thank our panelists this afternoon for their input. And again, thank you to Teffy for bringing us all together for this.
Thank you, Dr. Persse and panelists, for an interesting discussion from a variety of perspectives. That was wonderful. And while I'm expressing my appreciation, I'd like to thank all of our presenters and panelists and our leaders for their support of this program. Additionally, I'd like to thank Carlos Plasencia of the Texas Department of State Health Services, Houston Region, Camille Bro, there she is in the back, of the School of Public Health, and from TEFI, Dana Farrar, Rocio Rodriguez, Leo Gabriel. I would also like to thank the many volunteers, and you'll see them in the room wearing blue shirts, who made today's event successful. Thank you. And as we prepare to depart, I'd like to leave you with some final thoughts about today's event. Wastewater-based epidemiology, and by extension, the science around it, will likely grow exponentially over the next decade, in part due to new technologies that facilitate our ability to analyze this material in novel ways. Technological advances in sequencing, spectrometry, sensors, logistics, and population and predictive modeling will move wastewater science forward as well. Of course, despite these advances, challenges remain. Our public health infrastructure has long been under-resourced. Better supporting this infrastructure will allow our public health professionals to accept, manage, and use wastewater data efficiently. So as you heard earlier, so that outbreaks can be identified as early as possible. Additionally, we must design and provide support for systems that enable quick and accurate communications and effective interagency cooperation. And this is one of the goals of TEFI. When new or re-emerging pathogens are detected in wastewater, we must use the most effective means of sharing information with both specific response groups and the general public. This includes ensuring that our healthcare providers receive the most advanced warning possible with the most accurate data possible, so that they may ready their personnel and their practices. Our elected officials need accurate, clear, and timely information so that they can make proactive decisions that will protect the public's health while maintaining a strong economy. I'm proud to share with you that we're working on these challenges with the support of TEFI, the Texas Department of State Health Services, Baylor College of Medicine, the City of Houston, utility providers like El Paso Water, and so many other dedicated partners. We will overcome these challenges. After all, we have a shared goal: to save Texans' lives, their livelihoods, and ultimately maintain a strong and healthy community. Together, we'll get there. So thank you, everyone, for joining us today, for your insightful questions and compelling conversations. Please be sure to complete today's evaluation survey. There's a QR code on all the tables. Everybody online, you're going to receive an email as soon as you close your browser. Completing that survey is going to help us go a long way towards developing next year's summit, and I hope you all come back. And don't forget to pick up your parking vouchers on your way out the door. Those are going to be with our volunteers near the check-in desk. And thank you again. Have a safe drive home.